Every regulation I'm going to discuss in this brief was created for a legitimate reason. They were responses to real harms: patient dumping, financial exploitation of vulnerable patients, sepsis deaths that were preventable. The intent behind each of these regulations is defensible. The implementation, however, created operational consequences that the regulation's architects did not anticipate, and those consequences contribute daily to the gridlock you are managing in your department. Complex systems respond to regulation in ways that are difficult to predict from the regulatory design table. You mandate a process, and the system adapts to comply with the mandated process in ways that produce unintended second-order effects. This is not a failure of regulation as a concept. Regulation is necessary. Safety mandates in aviation produce safer air travel. Pharmaceutical regulation produces safer drugs. The question is not whether to regulate, but how to account for adaptive system behavior when designing and implementing regulatory requirements. Emergency departments are complex adaptive systems. When you impose a new process requirement, the department adapts. Sometimes the adaptation improves care, sometimes it creates new bottlenecks, and sometimes it does both simultaneously in ways that are impossible to separate cleanly. EMTALA was enacted in 1986 to address patient dumping, the practice of transferring or refusing care to patients based on their insurance status or ability to pay. The law required emergency departments to evaluate all patients presenting with an emergency medical condition and to stabilize them before transfer. The regulatory outcome was correct. Patient dumping largely stopped. The unintended consequence: emergency departments became the legally mandated point of care for all patients, regardless of whether their condition required emergency care. EMTALA does not require a patient to have an emergency medical condition to receive a medical screening exam. Any patient who presents and requests evaluation is entitled to one. The result is that EDS serve as the safety net provider for the entire healthcare system, absorbing primary care failures, mental health system failures, substance use system failures, without the staffing, physical space, or funding models designed for those roles. EMTALA solved one problem and created the operational context for several others. The regulations are not going away. Your operational task is to work within them while mitigating their adverse effects. For EMTALA, understand that you are functioning as a safety net for your entire healthcare community. Advocate for the upstream system, primary care access, behavioral health beds, substance use treatment. That would reduce the demand placed on your department by failures in those systems. For observation rules, document inpatient admission criteria explicitly when they are met. The 2 Midnight Rule documentation protects your patients from inappropriate down classification. Know the criteria, use them. For sepsis protocols, identify the highest yield elements of your bundle, antibiotics and source identification, and protect those execution times. Work with your team to streamline bundle initiation under surge conditions so that compliance doesn't require pulling resources from other critical patients. CMS observation rules were designed to control Medicare expenditure on hospital admissions. By requiring more rigorous documentation of medical necessity for inpatient admissions and scrutinizing short inpatient stays, CMS intended to eliminate inappropriate admissions driven by financial rather than clinical incentives. The consequence: hospitals became conservative about inpatient admissions, increasing observation placements for patients who previously would have been admitted. Observation patients occupy hospital beds, often the same beds that inpatient patients would occupy, with a different billing classification. The result is an increase in ED boarding. Hospitals with conservative inpatient admission policies hold more patients in observation status, which fills their medical floors with outpatient classified patients, which reduces bed availability for ED admits, which increases boarding. A cost control regulation for inpatient admissions became a driver of ED operational crisis. 3 things. First, understand the original intent of each major regulation affecting your practice. Regulations designed for bad reasons should be challenged. Regulations designed for good reasons with bad implementation should be modified through engagement with the design process, through professional societies, advocacy, and quality improvement data. Second, collect data on regulatory burden. When EMTALA-driven non-emergency visits consume 30% of your department's capacity, that number is an argument for healthcare system reform. Make it visible. Third, when regulations create operational conflict, when following the letter of the regulation conflicts with optimal patient care, document the conflict. That documentation is the raw material for regulatory reform. This is Global MedOps Command, a clinical brief series. Well-intended regulations deserve honest evaluation of their operational consequences. The path to better regulation runs through better data and better advocacy. Final brief in the series, what emergency medicine will look like in 10 years. Stay prepared, stay educated. Out.